Well, hello, everybody, and welcome to concurrent session 1.1, Stigma of Drug Use, Treatment, and Harm Reduction. Apologies for the brief delay. We were just having some technical challenges. Our moderator, Dr. Kim Sue, will hopefully be here in just a few minutes, but I'm going to go ahead and introduce the rest of the panel to get us started here. Monique Tula is the Executive Director of the National Harm Reduction Coalition. Michael Pond is a psychotherapist and author. Dr. Yngvild Olsen is the Medical Director of the Institutes for Behavior Resources and Reach Health Services in Baltimore City. And Dr. Jonathan Giftos is the Medical Director of Addiction Medicine and Drug User Health at Project Renewal, a nonprofit organization that provides health, housing, and jobs to people experiencing homelessness. Thank you all so much for being here. And fantastic, Dr. Sue has arrived. All I've done so far is introduce the panel. So now I can introduce our moderator, Dr. Kim Sue, who is the Medical Director, National Harm Reduction Coalition, and an instructor in the program of Addiction Medicine at Yale School of Medicine. Dr. Sue, thanks so much for being here to lead this panel. Take it away.
Oh, thank you so much. Sorry for I was in a limbo breakout waiting room. It's my pleasure to have these amazing people to talk about this really important issue. This is something that we all have been thinking about and dealing with in all of our work, and as we push for systemic change from both the clinic level to syringe service programs to federal and state advocacy, we know that stigma has so many effects on people. So again, this is the breakout where we're going to talk about the stigma of substance use, treatment, and harm reduction. And we're really going to focus on many of the current system's failures, but also ways that we can do better. And we hope that we have some really great discussion with you all. So to get started, we're going to start off with Monique. And Monique, if you could introduce yourself, tell us your story, what work you do, and what you're focusing on right now, it would be great. And Monique is my colleague at National Harm Reduction Coalition and our fearless leader.
Thanks, Kim. Yes, I'm the Executive Director of the National Harm Reduction Coalition. I've been there 5 years. It'll be 5 years in August, which feels a little unreal to me. I've been a practicing harm reductionist for going on 25 years now. Also seems a little surreal. But about 6 years or so, I read the book by Johann Hari called Chasing the Scream. And I think as part of his book tour, he did a TED Talk where he talks about what he believes to be the cause of addiction, any kind of addiction. And I have to say the way he stated his argument really helped me see things in a very different light in terms of addiction and recovery. So according to Hari, the cause of addiction is actually the lack of human connection. He says that human beings have a natural innate need to bond with each other. And so when we're happy and we're healthy, we'll bond and connect with each other. But if we can't do that because we've been traumatized or isolated or, beaten down by life, we'll find something to bond with that gives us some sense of relief because that's our nature. So Hari believes, and I believe as well, that the opposite of addiction actually isn't sobriety. The opposite of addiction is connection. And, we all know that societally we have a really long way to go in terms of embodying this belief, but we are making a bit of progress. And about 10 years ago, SAMHSA worked with a variety of community stakeholders to develop their definition of recovery. So they say that recovery is a process of change through which people improve their health and wellness, live a self-directed life, and strive to reach their full potential. And there's 4 major dimensions that support this life in recovery, including health, home, purpose, and community. So health, overcoming or managing disease or symptoms, and making informed and healthy choices that support well-being. Home, obviously a stable and safe place to live. Purpose, meaningful daily activities like a job or school or volunteering or something creative to do. And the independence and income to support ourselves. And then lastly, community, positive connections and bonds with other human beings. So having social networks that provide the kind of support and friendship and love and hope that every person on the planet deserves. That's how I think about recovery.
Great. Thanks for framing the introduction. So next we're going to go to Mike Pond in Vancouver. Hi, Mike.
Hello, everybody. Can you hear me okay? So yes, I'm Mike Pond, and I'd like to thank the National Academy of Medicine and the Dell School of Medicine and Shatterproof for inviting me to this, what I believe is a really important event. So I'm a psychotherapist on Vancouver Island, BC, Canada, and I specialize in addictions and trauma. I'm also the father of 3 sons. I'm a grandfather times 6, and I'm really trying to slow down and work part-time so I can actually immerse myself in this stunning part of the world where we live. Spirit Bay on Vancouver Island, where there's orcas out in the bay and whales and dolphins and eagles and sea lions and salmon, crab, prawns. It's just amazing. So I built a pretty idyllic life in British Columbia's Okanagan, which is Canada's wine country. Not an easy place to get sober. I had a thriving practice with 4 associates. And as my sons grew, I got sucked into working even more. And there was such a need. I had school board contracts and contracts with law enforcement, with our First Nations, and from critical incident stress management to the downstream effects of Canada's Indian residential school system. Although we didn't call it that back then, I lived with a lot of vicarious trauma. I began to drink a lot more, and when I found myself trying to stop, I just couldn't. The more I tried, the deeper alcohol took its hold on me. I repeatedly tried AA, and I was never able to quite work the program and make it work for me. Eventually, my business contracts all slipped away. My employees quit. My wife told me to leave. And after months of living in seedy motels, I took a Crayon bus to Vancouver, and I ended up homeless and destitute on Vancouver's notorious downtown east side. From there, I began a downward spiral through run-down, rat-infested recovery houses, rehabs, hospitals, and finally prison. I lost everything. I lost my home, my practice, my family, and my dignity. But I gained some stunning insight. As a professional, pretty well everything I knew about treating substance use was wrong. And most of all, it was my own complicity in the shaming of my substance-using clients, telling them to go and get sober first before we could even begin therapy. Stigma's everywhere. So here's a few samples from my Stigma highlights reel. In the medical system, I was routinely stigmatized and humiliated when I sought treatment. I counted at least 31 trips to the emergency department seeking help and got instead from doctors and other medical staff. Mr. Pond, don't you know there are real sick people here? I don't want to see you in my ER again. What part of this aren't you getting? Oh, you're one of those bleeding heart liberal social workers from the 80s. I really like that one. And I often left with nothing more than an Ativan and a bus pass. None of this treatment made my substance use disorder better. In one recovery house, the social worker in charge says the following things to me. Oh, so you want to off yourself, do you? Well, come on then, let's go. I'll buy a rope. I'll drive you to the bridge. And from that same guy, I heard a camera snap. And I looked up and he was taking a picture of me and said, I'm going to send this to your kids, Pond, so they can see what a sick fuck you really are. And when I went to my bank and went to assess the status of my accounts, the teller made a grand show of publicly cutting up my credit and debit cards. Then there was the cold glares and combined with the look of disdain on the face of the secretary in the medical monitoring office, where I attended random urinalysis checks for 2 years. I spent 29 days in intensive care, near death from a bacterial lung infection. One evening, the night nurse quietly whispered in my ear, "You know you brought this on yourself, don't you?" And in prison, how many times did I hear, "This is where it takes you, jails, institutions, and death." And how did that stigma impact me? Well, I was humiliated. I felt excluded. As Monique said, alienated, disconnected, isolated, bullied, and compounded by my already deep levels of depression and anxiety and PTSD. I eventually slipped into psychosis and was actively suicidal. I felt hopeless, of course, and I wanted to just drink more. And for people with no money, this kind of punitive approach is pervasive in treatment. Lay people, often uneducated, whose only skill is being sober themselves, often run the typically 12-step abstinence-based programs. It works if you work it. You're not working it hard enough. That's the perspective. And the system relies mostly on untrained non-professionals to provide treatment for complex bio, psycho, social, and economic disorder. We're sick, and that's so wrong. I was a privileged guy until I had no money left. Most stigmatizing of it all is being sent to prison for a mental health condition. I served 30 days from a drunk driving related conviction. Yes, there's no question I broke the law and I endangered people, and I deserved some punishment. But what would have been more effective would have been sentencing me to treatment. And when I was in prison, I did a rough poll of my fellow inmates. And about 75% of them were in there for petty crimes related to substance use. This experience truly opened my eyes. If I got out of there alive, I was determined to try to change the system. And how did I finally get well? Well, I shifted my focus to not relying on the system to help me. It was my own willpower, resilience, motivation, and support from others. And I'd get well despite the system. I'd get sober the best way I knew how, and actually got better, not necessarily sober. I got a job as a psychiatric nurse, a field I hadn't worked in 20 years, and I kept it through a medical monitoring agreement. I threw myself headlong into fitness, gym, yoga 3 times a day, and new healthy relationships. And then I met my partner, currently Maureen, on Plenty of Fish. And on our first date, I came clean about almost everything, especially since I couldn't drive for 3 years. She said she wasn't sure she wanted to date me, but she sure wanted to write a book with me. So we did. We wrote the book, Wasted. And we made a documentary for the Canadian Broadcasting Corporation about my search for evidence-based substance use treatment. So we had lots of success in doing media, speaking at conferences, and then came the backlash. And some were pretty horrible, sometimes threatening emails from those I thought I disrespected in AA. Maureen was called codependent and enabler, and much worse than that. Threats to her life. Members of the traditional recovery community accused me of being a shill for Big Pharma because I advocated for medications to help with the treatment of substance use. I was invited to speak at the Western Canadian Addictions Forum, and my invite was rescinded when several of the abstinence-based so-called medical addiction experts threatened to boycott the conference. I was asked to take part in a Vancouver committee on homelessness, but my feedback was disregarded because I believe in low barrier housing. In too many shelters, you can't get in if you're using, and if you do use, you get kicked out. I found the mainstream abstinence-based treatment industry in Vancouver has got pretty savvy about using harm reduction to window dress traditional rehab. They have a big conference every year called Recovery Capital, and usually headline the conference on day one with a big star of the harm reduction movement. But the other 90% of the conference promotes the same old players with the same old solutions. Abstinence only. Just get sober. Just get clean. There's so much to fight back about, and we found the process exhausting, and we burned out. I found myself to be a voice in the wilderness. Well, now I truly am in the wilderness, and I'm super happy about it. Still fighting stigma everywhere I can, but not letting it eat up my life. We got lots of young people taking up the challenge. So my practice focus now is harm reduction, any positive change, as Diane Bigg said, and psychedelics. My final thoughts. We must adopt a harm reduction approach where you don't get kicked out of treatment for relapsing. We must decriminalize drugs for personal use. Substance use is a health condition and needs to be folded into modern health care. In Canada, that means covered by the Canada Health Act. Community-based primary care, reforming the system, develop a path to healthcare reform, and use the same philosophy across the board. Easy access, clear entry point, one-stop shop. We need to get real about public policy in alcohol and other drugs. And the industry has made tremendous gains in the last decade, pushing back against regulations. We need a public education campaign to counter the flow of messages from big alcohol. And the 5 words and phrases upon which so much stigma is scaffolded: alcoholic, addict, junkie, drug abuser, codependent, and enabler. Yes, we even shame the people who want to help us, the people who love us.
Mike, thank you so much. That was really it's incredible to hear your journey and your thoughts on how we can be better. And it's wonderful, to see to be in community with you.
Appreciate it.
Well, now we'll go over to Dr. Yngvild Olsen, and I do think, building on what Monique and Mike have kind of laid out, we're going to transition to how it is to provide that care and to advocate for a more compassionate, respectful, and dignified, quote, treatment of people who use drugs.
Thank you. And both Monique and Mike, especially Mike, that's just an amazing story. And, I think part of what your story resonates with me is really just the advocacy and the anger that I feel as a healthcare professional who is really trying to, also kind of make things better. So I'm Yngvild Olsen. I am an addiction medicine specialist and an internist in Baltimore. And where I work and what I have been doing for the past 20 plus years is really focusing on providing comprehensive quality care for people with opiate use disorder, all substance use disorders, in a safe, non-judgmental space that really seeks to minimize harm and promote health. The American Society of Addiction Medicine, where I also have been very active, we have a definition of addiction as a complex, chronic, treatable medical disease that involves complex interactions between brain circuits, genetics, the environment, and an individual's life experiences. So all of those things that Monique and Mike, that you've both been speaking to, I think get encompassed in that definition. And that, that complexity, I think, unfortunately, is not the way that our systems are built. It's not the way that our healthcare providers are educated. It's not the way that we finance these systems. And at the root of much of this is really stigma and discrimination. I would say it's, stigma is kind of the attitudes, the discrimination is really then what people experience. And, just to start, I have lots of examples that I can cite, in my work from my patients, at people that I have, been trying to help. But there's one that really sticks out, I think, kind of that's relevant to this conversation, and then we can talk more about, how we really change things. And that is that I had an opportunity many years ago. I was the deputy health officer for a local health department in Maryland. And we, as the health department, funded a long-term recovery house, a long-term house and recovery program for people with substance use disorders. And we also happened to run an opioid treatment program through the health department. And so we provided methadone. That was really kind of the medication at the time that we had access to. And I had a young man in his 20s, late 20s, who had been struggling with an opiate use disorder for about 10 years. He had been in and out of residential treatment settings, similar to your experience, Mike. He had been in drug court. He had, been in and out of various different, also outpatient settings, intensive outpatient. And every time he was not able to sustain kind of the abstinence, I think that the treatment programs and that all of his health professionals, that was what they told him he had to get to. He came to our opioid treatment program very ambivalent about methadone, not necessarily sure that he really wanted to take this. His father, was very supportive of his recovery journey, but also was not very sure about methadone. And but he started because he said, nothing else has worked. I got to do something different. And he actually stabilized fairly quickly. But he really wanted more wraparound services. He wanted more support. And so the halfway house, the recovery house that we funded, we thought, he would be a fantastic. He fits all of their criteria. So we referred him, and he was soundly rejected. And the reason for the rejection, they said, no, we just don't take people on methadone. And I remember calling the executive director and just, really saying, look, we fund you. We fund a third of your total annual operating budget. Like, this is discrimination. And he said, well, no, we just have a policy. We don't take people on methadone. And I called our health officer. I called the state. We had a meeting with their executive committee. We talked with them, with the head of the Behavioral Health Administration at the time where their funds originated. And the answer still was, nope, I don't think we're going to take him. And eventually, the health officer and I met with their board of directors. We did a big presentation on the disease of addiction, what happens in the brain, medications, how they work, what the evidence is for significant reductions in mortality, morbidity, increases in quality of life. And one of the board members, I distinctly remember, said, we thought this way about antidepressants 25 years ago. We really didn't take people on antidepressants 25 years ago, and now we do. So maybe we can change. Maybe in 25 years, maybe we'll think differently about methadone, but I doubt it. And they decided to reject tens of thousands of dollars that we were giving them, and they elected not to take it, rather than have to take patients on people on methadone. The young man was devastated, but not surprised, because this is what he had been hearing kind of from friends and family, and he ended up moving in with his father and continued on coming to us for services and treatment, and including the methadone. But after a while, he stopped coming. And it just breaks my heart. We lost track of him. And it just breaks my heart knowing that, I don't know what happened to him. And that the discrimination that, he faced because of a medication, that, we don't think this way about insulin for diabetes. We don't think this way about any other medication. But the discrimination, and the advocacy that it really takes to make sure that we're not only discriminating against people who are using substances, have a substance use disorder, but even the treatments that we provide, we need to do something different. So I'll end there. Thanks.
Thank you so much. And, I'm not sure when you were talking about that particular instance, but I'm, very, aware, and we're all aware that those are still, happening to our patients and friends today. And we'll go to Dr. Giftos, who is one of my former colleagues from Rikers. And I think he's been in the thick of it in the last year, thinking about stigma in his new position at Project Renewal in New York City and the ways it affects the care of people experiencing homelessness and or using substances. So we'll go to you. Thanks.
Thank you, Kim. It's really a pleasure to be here on this panel with everybody and to hear my co-panelists' stories. It's very inspiring, and I think so. Just to kind of start, I'm Jonathan Giftos. I'm a general internist and an addiction medicine specialist. I currently serve as the medical director for addiction medicine and drug user health at Project Renewal. As Dr. Sue said, a homeless services nonprofit in New York City that provides housing, healthcare, and jobs for people experiencing homelessness. I'm sort of new to this position. I started right before the pandemic, actually. Before taking this position, I worked for 4 years in correctional health on Rikers Island, overseeing diversion, harm reduction, treatment, and reentry services for incarcerated people who use drugs. A big part of the work for me was serving as the medical director of the opioid treatment program on Rikers Island, which provided methadone or buprenorphine to patients who were incarcerated. And what Dr. Olsen said about stigma against methadone resonates very strongly with me, given some of the work that I was doing at the time. At the time, there was a lot of, Rikers had one of the few methadone programs, jail-based methadone programs in the country. But despite having a program, there was still stigma against the medications in the jail system, and not as many patients accessed it for a variety of reasons. So a big part of my work there at the time was expanding access to methadone and buprenorphine. We were able to improve treatment rates from 25 to over 75%. We reduced post-release overdose risk by over 80%, and there wasn't a single in-custody overdose death during the years that I was working in that program, which is a real testament just to the efficacy of the medication when it's really made available to people who need it. It really should be the standard of care in all settings. So my current work involves a mix of office-based addiction work. I manage a large panel of patients on buprenorphine and treat hepatitis C, along with a cohort of providers working in integrated medical clinics that are inside of shelters or transitional or supportive housing, or mobile medical vans that serve people on the street. I also oversee what are called low-threshold licensed addiction treatment programs. Some of them are outpatient that provide counseling, groups, occupational therapy, recovery support for people experiencing harms from their substance use. I also oversee what are called residential crisis programs that serve people struggling with chaotic substance use, many living in the New York City shelter system or on the street. I've been part of an organization over the last year that's worked really hard to protect people living in congregate settings from COVID. Many of our clients living in our housing programs got relocated into hotels across the city, many in neighborhoods that historically hadn't welcomed people experiencing homelessness, people who use drugs, and they experienced a tremendous backlash, and I'll talk about that briefly. Many of our patients have a history of complex trauma, that is to say, longstanding exposure to violence, abandonment, neglect, and mistreatment that impacts how they access services. For many, that includes incarceration as a form of trauma, but it also includes traumatic experiences with service providers, including the very programs aimed to care for them, such as hospitals, clinics, and our treatment programs. But I work in a city that has no shortage of services. So it's a service-rich environment. And so the availability of services is relatively high. But what I've come to really appreciate, and this has really resonated in Mike's story, that just because something's available doesn't mean that it's accessible to you or acceptable. So a big part of the work that I do, and it's a real long journey, is really focused on improving the accessibility. In other words, is the care there for you when you need it and you know how to access it? And the acceptability. Does this place accept me as I am, as my whole self? Do they respect my dignity as a human being? Do I feel comfortable in this space? So the accessibility and acceptability of care in a city where services are otherwise relatively available as compared to other parts of the country. And a big part of that is really working to kind of build programs that are warm and welcoming, something that I think we all we don't appreciate walking into spaces and not being greeted warmly, but many of our people struggling with chaotic substance use are treated terribly, even when they're accessing services. And so spaces that are warm and welcoming, telling people that I'm glad you're here, it's good to see you, I'm happy that you came to us. They think creatively about safety, so we struggle a lot to think about how to really think about safety holistically. Is it sometimes people often are programs for using drugs. How is that safer for anyone to be discharged to the street than to work with them while they're in your program? That accept people as their whole selves, creating space to see people's strengths. I think so much of our work tends to be deficit focused, and that really kind of limits people to their struggle. And I think there's so much strength in a lot of the people we work with, and creating space to see that are trauma informed. Of course, we really work hard to avoid re-traumatizing people. I think so many settings really re-traumatize people, and then incorporate and respond to client feedback or concerns. So we really kind of making programs that are for and by the people that are served. So I'll close because I look forward to kind of the moderated discussion, but I just want to close by saying that sort of valuing these things is really just the start, and it doesn't mean that your organization or your program will immediately reflect these values in practice. Crafting policy, training and supporting staff, managing competing pressures from regulatory bodies or funding sources, or community sort of aggression like we experienced in some of our relocations of our guests into hotels, the way that they were treated by the community, the way they were described by the community. I had several of our clients overdosed publicly and had their pictures blasted on Twitter, or were told that they were, used all the sort of awful words to describe them publicly, followed around with video cameras, et cetera. This stuff puts pressure, it ended up putting pressure on our mayor to actually like relocate the clients themselves. So, and we had to sort of respond to that. So, the balancing and all of these competing pressures to kind of do right by the people we serve is challenging. But I think we do a tremendous amount of harm when we aim to serve but fail to deliver on these values. And so I look forward to continuing to learn from others as we try to move the work in the field forward. So thank you.
Thank you so much, everyone. And we're gonna move into our discussion. And please don't feel shy to type in any questions you have for any of our amazing panelists while we start the Q&A. And the first question that I have is for Monique, Mike, and John, but anyone really can jump in if you feel so moved. And really reflecting on how people have experienced the harms of the current treatment and existing social service system in North America. We can even say to extend to our Canadian colleagues. Is there a way in which you think that harm reduction as a philosophy, as a practical strategy, can do better, or supplement, augment, expand the ability to provide compassionate care as opposed to traditional treatment or abstinence-based strategies? Monique, do you wanna go?
Yeah, sure. I think about this an awful lot, right? Like I get paid to think about this. And, although we as in harm reductionists are often seen as, sort of the agitators who are on the, total opposite end of the treatment spectrum, there's plenty of us who, embrace the pursuit of a life in recovery. But the reality is that recovery is not, it's not for everyone. it's just not for everyone. So, I was thinking back, like kind of comparing the dimensions of recovery that SAMHSA came up with, right, with harm reduction principles. Both sets of principles are, people-centered, they're pragmatic, they take into consideration, really important cultural factors like race and poverty, stigma, social disapproval of drugs in the people who use them. So rather than seeing harm reduction being on the treatment spectrum, instead, we see treatment as part of a broader harm reduction framework, right? Where chaotic use is on one end and abstinence, maybe on the other end, but there's a whole lot of room in between those two variables. And, the harm reduction interventions that we often talk about, so things like syringe service programs, safe consumption spaces, medication for opioid use disorder, naloxone distribution, all of these interventions can be pathways to personal responsibility and autonomy because they put the power of choice in the hands of people who use drugs. So they're all examples of really pragmatic and person-centered harm reduction approaches, and they can be extremely successful at, obviously reducing infectious disease transmission, overdose, and then linking people to treatment and recovery. So for me and for harm reductionists, these kinds of people-first approaches really help to create the kind of space that relationships can be built in, spaces that should be free of judgment anyway. Harm reduction really demands that we view people as whole human beings who are worthy of, not just basic human rights, but love and acceptance.
If I could just maybe add to that, I think that the way I guess I also kind of think of harm reduction very much as that larger concept, and that treatment, and because I think for a long time there have been these silos, right? So silos between even prevention, harm reduction, treatment, and recovery, and it's really it's a continuum. It's all kind of blended together because addiction as a chronic disease, much like, and there are people who debate whether that's, that concept. But if you kind of take that, at least that there's a chronic illness component, that there's a, kind of a, it doesn't go away after 7 days, right? And you don't give people an antibiotic for addiction like you do with pneumonia, and it doesn't, kind of go away quickly. That there is this just this continuum, and that things kind of the approaches. To me, it's really about kind of the approaches and the principles of kind of respect and dignity and understanding where people are coming from. And we do that in other parts of medicine. So, I think to me that the analogy, like I love the analogy of diabetes because, we don't blame people, or we shouldn't be blaming people, kind of for the fact that they have very high sugar levels in their system. We don't say, kind of, oh, you're taking insulin, you're such a, you're like a bad person, as I think, Mike was speaking to. And that when we talk about minimizing harm and promoting health, we do that in lots of other areas of medicine without kind of question. And so, why we have kind of created these very separate silos within the, substance use addiction space doesn't do anybody any good. And we can argue until the day is long about, the why, and the what, but ultimately we're all kind of committed to, and we should all be committed to the same thing, which is really helping the people who, are affected by this. And whether that's on the street, whether it's, in a house, whether it's in the hospital or the emergency department. And so, it's just, I think it's unfortunate to me that, that we still are really living with a legacy of, looking at addiction as a moral failing, looking at substance use as, this kind of bad behavior, and then it makes you a bad person, and that that there's something, just very wrong and morally, deficient with people with people that that are using substances. And people have been, humanity has been using substances for thousands and thousands and thousands of years. This is not something that that all of a sudden kind of started. So so I really appreciate the Monique's comments and everyone's comments.
Mike, do you have any particular thoughts on how you've developed your strategies as a therapist using harm reduction that sort of you can give based on your experiences both as a patient in these hostile systems and give us some tips about how you think about this with your patients and yourself?
Well, of course, given what I went through and through that process, I emerged from it with a pretty profound sense of empathy. As I said earlier, I was pretty judgmental, and I had my ideas, and they were wrong. And then I was given the opportunity to experience it, to be on the other side, so to speak, and experience what a person goes through when they don't have the resources and they're struggling. And healthcare and the recovery community, it tends to treat addiction as binary. You're either an addict or you're not, or you're an alcoholic or you're not, or you're clean or you're not. And abstinence is the measure. And I don't use that as a measure necessarily. It's on the continuum, but when I'm working with people, and I tend to work more with people with alcohol use disorder because that's my story and that's what draws people into my work. And I just say, well, where do you want to go with this? What do you want to do with this? Do you want to be abstinent? Do you want to look at moderation management? And so, meeting the patient where they're at and working from that and having them direct it. And I say, who has the most wisdom about you? Who has the most wisdom about you? And they kind of look at me, and then eventually it's, well, of course, you do. I do. I have the most wisdom about me. I know me very well. What a concept. And although the DSM-5 now uses SUD on a continuum, mild, moderate, or severe, the traditional model gives it lip service. And I'm not here to disrespect AA at all, but that's the program that most of our treatment is based on at some level. And it demands abstinence. And most rehabs train you as that's the go-to aftercare. The mutual social support is AA and NA. That's 12-step programs. And by the way, do you know today is the day Bill Wilson, Bob Smith founded AA in 1935? Amazing. Most rehabs kick you out for lapsing, or you get punished if or when you return. And when you do return, then you're probably on close observation and in a side room. And when I was kicked out of rehab for drinking while on a pass, it was the group consciousness that voted me out of treatment. These are my fellow clients, fellow patients, actually kicked me out of treatment. So there's this degree of kind of lateral bullying or discrimination that happens, right? There's a pecking order within that system. And the director informed me that I could return in 30 days if I stayed sober. So I was put out in the street again with all my belongings, which were in 2 plastic garbage bags. I think you guys call them trash bags. It was the worst snowstorm in 75 years, and I almost froze to death while I was on the street. We have recovery day, we have recovery week, we have recovery month, and we celebrate being, I'm an addict and I'm clean and I'm sober and I'm proud, which is fine. But what is that message giving the public, right? We yell to the rooftops, our term of sobriety, which is fine. I went into one AA meeting in White Rock here in British Columbia. I just happened to walk in, and it was an individual's cake, and he was getting his second 20-year cake. So in 40 years, he used or got drunk on one weekend. And that was the focus of that meeting. I'm going, holy cow, you went 40 years and only drank once or used once. So there's a lack of the shame people who don't get well that way. I was accused of taking an easier, softer way because I was prescribed Vivitrol. And quite frankly, it saved my life. It's based on a white Protestant male model. The war on drugs is not that, it's a war on drug users. A colleague of mine is a lawyer with one of the largest health unions here in Canada. And he says he advises the union members to not disclose to their employer because there's going to be inevitable repercussions. There's going to be judgment, discrimination, punishment, discipline. In my experience, our healthcare judges and discriminates against us. But most judgment and disdain is reserved for the so-called illicit drug users. Right off the bat, we have to wait so long to get into treatment, and we pay outrageous amounts of money for private treatment, which means our lives are not considered an urgent priority, even though most substance use disorders, if they progress, are life-threatening. I met an AA member, he was a Vancouver police officer, 30 years of experience working in downtown East Side. He says, I just step right over the addicts when they're lying on the curb, shooting up. We know substance use disorders are by definition chronic relapse conditions, but often healthcare professionals get frustrated and impatient with those who exhibit the very symptoms of the disorder. And so, yes, we relapse, that dreaded word, relapse, which is kind of one of the defining criteria for the diagnosis being accurate. We're a huge pain in the ass, I know that. And we can be very unsavory. But if you saw us displaying symptoms of bipolar disorder, schizophrenia, you'd see us as more deserving of treatment. It's a deeply held belief in so many of us still that addiction's a moral problem, not a medical, social, psychological, economic, cultural problem.
Thank you so much. We only have about we only have about 6 more minutes, but I did just want to use my moderator's prerogative to jump in. And there's a harm reduction coalition had almost 15 or 20 years ago had a roundtable on harm reduction and recovery, and many people had many wonderful and eloquent things to say about it. And Kevin Irwin said, at their core, both recovery and harm reduction are about resisting stigma and discrimination, building resilience, cultivating hope, supporting any positive change towards one's own self-actualization of health and wellness, and for those in our various communities. So, we in the harm reduction community are inclusive of all people and all strategies that work for people, including abstinence. And we really, again, see and I talk to patients as well and about people moving on a continuum and moving back and forth with different substances over time. Like that, it really is a complex reality that people have to different substances over time. And that's why, as an anthropologist, I think it's so fascinating and important to talk about. One thing that we're having many questions, but one thing that I think is important for us to talk about is the stigma of addiction treatment, pain and pain treatment, harm reduction, and structural racism. And I think this has been on everyone's minds, in the last year or so, as we've kind of culturally, been, shocked, and horrified about the way that sort of racism and the war on drugs and criminalization of substance use really has led to the death of many Black people and Indigenous people. And so if we can just, if anyone wants to get in on this part, I think that a lot of our audience members might be thinking about this and ways that we can address this in our lives and in our work.
Well, I have a lot to say about it, but So I think about, we talk about cultural competency, right? We've been talking about cultural competency for a decade now, and we've had varying levels of success. But what I want to push us to think is, what does it mean to move beyond cultural competency to actually dismantling structures that sustain and promote oppression? So, for me, any kind of movement to reform a structure or a system or institution or practice, any movement that's focused in that area that have a history of inflicting harm on the very people that we're supposed to be serving, that movement has to have a critical orientation toward racial injustice, because without it, you're essentially addressing the consequences and the systems of injustice rather than the root causes, right? So, for example, America's current obsession with, white opioid users is really evident in our drug courts that often favor white over Black and brown defendants, right? And yet many advocates are shy away from the kinds of conversations about individual and institutional racism in favor of, easier and, short-term solutions. So this fear of confronting racism risks building upon rather than dismantling the root cause of the problems that we're trying to fix. And so I think of harm reduction as actually could be an innovative approach to expand our thinking around how racism shows up in our day-to-day interactions and are, fraught in our institutions. So most of us who are familiar with harm reduction tools, we use them to try and mitigate the harms of drug use rather than focusing solely on treatment or abstinence. But since the beginning, Black and brown harm reduction advocates have long seen the harm reduction's commitment to health and human rights as a lens through which we can address the harms that have been caused by overarching discriminatory public health and criminal justice systems. So advocates view that focus not only as reducing the harms that drugs cause to people, but addressing the harms that society inflicts upon them.
What she said. I mean, I just couldn't agree more. And I think, Monique, that, really the harm and I think what everyone has really been speaking to is, the harm reduction principles, because they also are non-judgmental and they put people first, and they essentially, demand respect and dignity for, kind of no matter what you look like, no matter who you are, that it allows the space, I think, also to then have those conversations that, for me, as a white privileged kind of, cis woman, like, can be also somewhat uncomfortable. But I think that, being able to sit with that discomfort, and understand that, that is discomfort that people have, Mike talked about it, kind of being thrown out of a halfway house into a snowstorm, like, so it's such an important critical issue, and one that we really need to spend a lot of time focusing on. And it's not going to happen overnight, but I think until we kind of really get to where we change those structures and change those systems, we're just going to keep circling around and around and around.
So I think our time is up, and I just want to thank all the panelists and the organizers, Shatterproof, National County Medicine, and Rich and Alana, for this wonderful panel. And, certainly the rest of the day is hopefully incredibly productive, and we hope to continue this work with you. We know that this is a long journey, and all of us are doing our piece in our corner of the world to make this a better and safer place for people who use drugs, and they can live in a world with dignity, respect, and compassion. Thank you.